Hello on Instagram, hello on Zoom. Hello Michael Höhne, back again, thanks for watching again. Okay, great. So, we are back to talk about the nervous system, and we want to talk about the nerves themselves today. We talked about different things already, about the basics of neurofunctional integration, functional neurology, why we want to look at it the way we do. We look at it, we talked about functional connectivity, because a lot of things out there are based on neuroplasticity, saying you have to train this, you have to train that, you have to repeat it, you have to do it over and over again. And this is absolutely right to do that if it needs to be trained. But sometimes it just needs to be reconnected or reintegrated to function. It's like plugging in a cable or taking away the noise in the cable or the disconnection in the cable, turning on the power, something like that. That's what we do here. So it's a short process of integrating function through the nervous system all over the body, all systems. That's what we do. So we talked about the different levels we look at. And when I talk about different levels, it's not that I mean that we are just working in that area, but we're working through that area into the nervous system. So we said receptor levels. So we worked, and that's what we did last time. We looked at the proprioceptive system. So how to just very easily test that and also integrate that. So giving some proprioceptive information into the system is what we're doing. So we're activating the receptors, and that's why we're saying we're working at the receptor level. But of course, we're not activating the receptors only. We're activating the tract that's going to the brain through the spinal cord and up to the brain stem, and so on, and eventually it goes to the cortex. So this is what we did last time. We worked with the proprioceptive system. I told you we could work with vibration, for example. The tools we use, tuning fork, I use 120 hertz, 128 hertz. As is my most used tuning fork, and of course something like this, a small massage device, which gives more deeper vibrational impulse into the tissue. You can also use those massage guns if you want to even go deeper, if you need to go deeper, if you have a system or a nerve that's in the deep fascia or in the deep parts of the muscle where you have a lot of muscle, like in the leg, you might want to use something more with more impact. So I'm going to just say hello to all the people here on Instagram watching. Thanks for coming by and watching. So what we want to do today, we want to talk more about the nerves. But before we do that, we just want to go through those 6 levels we want to talk about. Receptor level, nerve level, that's today's issue. Then of course you have the spinal cord, which also already has integrative function. It's not only a pathway for the signals, but it's also a regulatory process. There's signaling going on, like the walking patterns are coming from the spinal cord, etc. So that's something we want to look at next time. Then we want to look at the brainstem. We want to look at the midbrain, which is the part where the hypothalamus is, the amygdala, the hippocampus, all those areas. And then we want to look at the cortex. So that's what we're going to do the next time. But this time we want to talk about nerves. So we have a nerve that's picking up signals or that's sending signals into the periphery. That's what we have. So, and to do that, a nerve needs some blood supply, for example. So the nerve needs a lot of energy. It has a high energy demand to signal, because signaling is an intensive process or an energy intensive process. So if you look at nerves, and usually in the textbooks you have these pictures of the nerves with the different layers, and I don't want to get into that because you can just pick up a textbook and look at that. I would like you to pick up a textbook and look for a picture that has the vascular system of the nerve, so you can see how much vascular system there is in the nerve. So then you realize how much blood flow there is in each nerve, even the small nerves, a lot of blood flow to supply the nerve with the energy it needs to function. So if you have a problem also on the receptor level, if I want to call it that way, so if I apply a stimulus to a certain receptor and the nerve is not signaling well, causing a dysfunction in the reaction of the body, then that could be not because the receptor is going wrong, or because the integration process in the spinal cord or in the brain is wrong, because the nerve is not supplied with enough energy to do its job. So that can cause that. So I have to look at the nerves themselves. So the blood supply. So if I have a blood supply, I must have a sympathetic innervation of the nerve. And that, of course, needs to be, because the sympathetic system will regulate the blood flow. So if I move my arm more, I need more blood flow, not only in my muscle, I also need more blood flow in my nerve to supply the muscle with information. So that's needed. So there must be a sympathetic system in the nerve also. So the German term, not a German term, the nomenclature would be nervi nervorum. So those are the nerves of the nerves. But besides the sympathetic system, there must also be a mechanical system, because the nerve is a mechanical structure and the nerve has certain mechanical properties that are quite interesting, changing its viscosity through stretching and things like that. But that's not what I want to talk about. What I want to talk about is how much stretch can a nerve tolerate. So if you take a nerve and you put it under stretch, they say that, and this is of course not really done in live humans, so we have to question the results all the time if that would be true in a live human. So the nerve can be stretched 10% of its total length. So 10% of its total length, it can be stretched. That's the only property it has in terms of elongation. So that's what it has. And up to 10%, they say in experiments, there will be damage in the nerve when you come up to the 10%, but that's reversible damage. So the nerve can change its structure and change back to what it was like. So if I fall and I really stretch my arm, I might stretch my fascia, I might stretch my tendons, my ligaments, all that, but I might also stretch my nerve and also my blood vessels. So that's a thing we're going to talk about at some other point. So stretching my nerve can impair the function of my nerve. So I have to find out if the nerve function is impaired, not in terms of the signaling it's supposed to do, but the metabolism and the proprioceptive, I want to say, surveillance. Because if I have mechanics in a system and I have structures that are that can break or can break down or can get irreversibly damaged through some stretching above 10%, that's what happens above 10%, I need to have a system that is looking after the nerve. So there must be a proprioceptive system on the nerve. That has to be. I haven't really found anything. If you guys know anything about this, I would be happy if you share some of that with me, because I was looking for some information on the proprioception of the nerves. Didn't really find anything, but of course with millions and millions of publications out there, I can't say I read through all of them and say there is none, okay? So if you have an idea, if you have something that shows the proprioceptive system of the nerve, you're welcome to share that with me. So here is what I believe there must be, this surveillance of the mechanics of the nerve. And if there is something like that, like in the joints, when I push my joint to the limit, my brain is going to signal pain. The same thing is happening with nerves. If I stretch them, I might think it's a pain in the joint or a pain in the muscle or in the fascia, but actually it's a pain in the nerve that shows up, that could show up. And if somebody comes in, like a patient this morning, having pain in his knee, he has a history of arthritis or of degeneration of his cartilage, yes, and he had Umstellungsosteotomie, we say in Germany. It's a reconstruction of the knee, shifting the angle, so to get some pressure of the medial part of the knee where the arthrosis is more progressive. And he's always had pain since then. So that's years now he's living with pain in his knee. So of course there's an aspect of muscle function and the joint capsule and all those things, but you have to consider also the other things going to the system, to the joint, to the muscle, and that's the arteries, the vessels, the blood vessels, and the nerves. So you have to take that into consideration, of course. And I have to say hi on Instagram. Thanks for watching here. And so taking that into account, you have to check for the nerves. So that's what I did. So we did some testing. We did some provocation of nerve tissue. And you can never be really sure if it's the nerve that you're really provoking here. But it turned out that more likely or more probably when we put stretch on the obturator nerve, it caused less pain in the knee. So that was interesting. this could be due to a dysfunction. So I went back and checked that with him. Of course, I did some testing, the way we test in neurofunctional integration, and found out that when I test for the nerve shows up, and that's what I'm going to show you how I test for nerve tissue damage or nerve tissue dysfunction. So that's what the giveaway for today, how I do that. So in his case, I would have thought more of the saphenal nerve, because that has some fibers going into the patella tendon. So his main pain today was right here. Before it was more on the medial side, where he has also the damage in his knee. So I was more thinking of that, but when I tested that, it didn't really show up. This one comes from the femoral nerve and goes down on the inside and goes all the way down to the leg. So we tested that. We tested some mechanical irritation on that nerve. That didn't change anything in the mechanics and in the pain of the knee, but challenging the obturator nerve, that did change something in terms of it was better. So probably there's two things that can happen. You have a lesser activation in the system. So if you activate it, the brain is saying, well, that's wonderful. Now I understand my knee better. I know where it is. I know how I can challenge or can get my muscles to work better. Or it can get worse. Both indicate a dysfunction. If it gets worse, it might be a hyperactivation. So the system is already activated to a state that if you put more activation in, the pain is coming more. So the pain is going up. Lesser activation and you activate it, the pain is going down. Okay, so those are two things that could happen, but of course that's an interpretation of what's going on. So we were looking for the obturator nerve, and we started working with that, and we started treating it, and afterwards his knee pain, of course, was better. Now the question is, does his knee pain get worse over the day? That's what we're going to have to see, but because today I saw him in the morning where he says my knee pain is moderate, but moderate for him was 2 out of 10. So already there was quite some pain going on in the morning, and that would go up during the day. So I'm looking forward to seeing him next time. And I gave him, and that's the good thing, I gave him a homework to do to activate that nerve tissue a few times during the day when he sees the pain coming up, to see if he can slow the pain down, because that's what it did in the beginning in our neurological testing. Activating the nerve tissue would dampen the pain, and that's maybe he can use that in the course of the day to keep the pain down and to start controlling the pain. Okay, so nervous tissue must have proprioceptive control. 10% reversible, over 10% irreversible damage to the nerve, so that has to be under control. So I was looking all those years, I was looking for a spot on the body, because that's what I always do. I try to kind of focus, how can I get tissue or certain functions down to maybe one point where I can, if I test through that point, I can get access to that system. And fortunately, through a lot of testing over the years, I always came back to C2. So C2, the spinal segment or spinal vertebrae C2. So why is that? So I remembered when I was in osteopathic school, they said that the dura is attached to the skull and attached to C2 and attached to the sacrum or parts of the sacrum. So those were the attachments they told us are there, and the rest is just loose dura. It turns out that's not true. So I looked in more recent studies of the dural tissue on the attachments to the spinal cord or to the spinal vertebrae, and it's basically attached everywhere. Maybe when somebody dies and when they open them up and then they look at that, when he's preserved in chemicals, those little ligaments, they deteriorate and you can't see them anymore. So that's why maybe they thought this is just attached in some big points, but actually it's not. It's attached all over the spinal cord. So that could not be the reason that C2 is the only attachment. But what I then found when I went further into researching that, I found that there is a structure called the myodural bridge. So this is a structure that where you have fibers from the dura going into the muscles of the spinal segments. And what they say it probably does is when you move your head and you have a lot of inclination here, extension, flexion, so the system doesn't collapse. This is to pull on the dura to open up the space between the dural sheaths. So that's what they say it basically does. It's like in the joints where you have those muscles that are there for to ensure that the capsule is not going to get into an impingement. So same thing here, probably at the dura. And maybe that's the reason, and I'm saying maybe because I don't know, maybe that's the reason why C2 is very sensitive to dural issues. And when I talk about the dura, I don't only talk about the dura and where the skull is and where the spinal cord is, but I also talk about the dura, which you don't call dura, on the nerves. So that's a connective tissue that just goes along. You just don't call it dura anymore when it's outside the spinal cord, but that's just a definition by term. So that's what's happening is you have a mechanical surrounding of the nervous tissue in the skull, in the spinal cord, and along the nerves all the way into the periphery. And it turns out that the C2 is a very, very good reference to find problems within nervous tissue function. And I'm talking about mechanical function in the nervous tissue. So that's what I'm here to talk about today, and I'm going to show you today. So let's have a look at the time. I want to see how much I talked. All right, it's 8:46. That's wonderful. So I talked 15 minutes, and I gave already quite a lot of information. And so I'll just start showing you. So my sister's here, my daughter's here. My God, my sister, yes. Come here, sister. That's because we always say, hi, sister. Okay, so here's my daughter. She came back like last time to work with us. So I can show you actually how to test for that. So if you have a patient who comes in, like my patient with a knee problem, of course you are at the knee. And if you're testing, if you're doing functional testing, mechanical testing at the knee, and you're not sure which structure are you testing right now, is it more fascia or is it more a blood vessel or is it more a nerve, I always go back to certain points, and this is the point I'm using for the nervous tissue, is C2, to figure out, does that have something to do with the dura or with the connective tissue around the nerve. So this works really well, so I'm really want you to try that when you see a patient and when you maybe test the way we test, or if you want to try to test the way we test, you can try that to find if the problem you're testing on somebody's knee or hip or back is maybe related to the dura or the nervous system from a mechanical point of view. So that's what you can do. So I then can go back. That's what I did with the patient. I did this morning. We challenged the nerve, and of course we challenged a whole bunch of other structures, fascia, muscle, and etc. And that changed the function of the knee. So then I went back to testing which part of the tissue, of the soft tissue, muscle, fascia, am I testing? It's very hard to define fascia and muscle in a certain way, but it's quite easy to define blood vessels and nervous tissue, and that's nervous tissue is through C2. So that's what I did. I tested on his knee where his nerves are, and it was more the obturator nerve that showed up, and that tested when I took C2 in conjunction with the peripheral tissue. That tested positive, and I'm going to just show you in a second what that means if you're not aware of how we test. And so then we could work with that, and I could write down, and that's what this is also for, write down on my diagnosis, so he has an affection of the obturator nerve. Okay, so it's not the tendon, it's not the ligament, it's not the joint capsule, it's the obturator nerve, so I can write that down as a diagnosis. Okay, so C2. So here we have the neck, and here we have C2, and everybody who has palpated human bodies knows how to palpate C2, so it sticks out a little bit. The dorsal, oh yes, my English, the dorsal part of the vertebrae sticks out quite a lot. Yeah, so the first one you encounter here is C2. So I can go on that, and if we test the way we test in neurofunction integration, of course what we do is we see if anything happens when I do this, when I just touch that vertebrae and just push slightly on it. You don't have to push hard, you don't have to break the neck, okay, and you don't have to like give an impulse, you just hold, but you should be on the bone, not just on the skin. The skin probably, or most of the time, will not do it, okay, so you have to go down to the bone. It's okay standing up, it's a little easier lying down. We're just going to work here standing up. So There's no problem when I do that. Of course, you know, muscle testing. If you use muscle testing, you can see how the muscle is working. We're working with sensory motor loops, and we're just trying to find out if we can distract sensory motor function. And that gives us a window into the function of the nervous system. And the more important part, because we already know there is a problem, the more important part is to find a solution. So that's what we want to do in a quite easy way, or in a quick way to do that. Okay, so what we just had before, because we already had our German session just before, we found a problem with the ophthalmic nerve here on the left side. So she fell a couple of times. She even has a little scar here, with a small indentation where she fell on her head. So that could irritate the nerve over a longer period of time. So that's what we found, and that's what we already integrated. So we're going to go look. So what we're going to do with her, because we don't have any clue, she's not saying she has any pain anywhere, so we're just going to look around, and it's quite normal to find something even if somebody's not in pain, because the body's really good at compensating things. But as a human being, especially as a kid, you jump around, you fall off the chair, you fall down the stairs, all these things happen, and that can affect nerve function in terms of nerve tissue function, and in the long run maybe something develops out of that. So that's what I always tell my patients when they come in and say, why is this happening right now? Because it has accumulated. Yeah, so there's just too much going on that's not going well, so then the body's not working well anymore. Okay, so here we go, and I'm just going to show you how that will work. So I take C2, and now you can just scan the body. And since most of the nerves, not all the nerves, but a lot of nerves also go into the skin or into the muscle just below the skin, you don't have to palpate very deep. Of course, maybe there's some nerves you have to go more into the deep tissue because it's not in the skin, like the suprascapularis, which is not innervating any skin, it's just innervating muscle and parts of the joint. So sometimes you have to dig a little deeper, I want to say. Okay, so you really want to get down to the tissue where the nerve is going through. Okay, so what you can just do, you can just scan. Okay, so we're just going to scan here, scan the head and the neck. Okay, and I always have my finger here, so then I can go through the arm, see if something shows up there. I can go through the down the back. Okay, see if there's something there. Okay, so here something is showing. So what kind of nerves do we have here? The scapularis nervus dorsalis scapulae, we would say when we say it in Latin. So that's a nerve going along here. We have the accessory nerve here, cranial nerve 11. So let's find out if we can take that to a more precise way. So I'm going right by the scapula. So that's where the nervus dorsalis scapulae would run along, and I'm just going to run along that. Okay, so that shows me an irritation. So is that in connection with C2? I just have to test because I haven't tested that. So it could just be that by running over that with my hand. I don't have my other hand on the neck. Just by running my hand over that, hold very strong. Okay, so not much is happening there. So I'm just slightly running over the skin, not with too much pressure, but also not with too little pressure. But I'm not as deep as to really grab the nerve and stretch it along, because that would be the next step. So this is an indication for a nerve tissue dysfunction, okay, in the course of the nervus scapularis, nervus dorsalis scapulae. So right along, it's going right along the edge right here, okay. So what I can do now is I can stretch the nerve. So that's what you do. You pull on the nerve because it's mechanically sensitive. Okay, so that's what I want to do. And if it's irritated, I want to force it into irritation. So what I can do, instead of using those two contacts indicating to me that we have a problem in the nervous tissue, I can let that point go right here. So I don't have my hand on the neck, and I just go here and I take the nerve and I pull it down. Okay, so you have to give it quite a bit of push. Okay, so take the nerve and just pull it down. All right, so you have to find a way to do that. I'm just pulling on the nerve. Okay, so that's what I'm doing, pulling on the nerve, and that way I can already irritate it, okay? You can also ask the patient to pull on the nerve. So the nervus dorsalis scapulae can be pulled on if you bring back your shoulder and you pull it down. So you're bringing the nerve down. What you most of the time need to do is you need to go into elongation. You pull away the nerve with the dura by taking your head into flexion and taking your head into side bending away from the side. And then you take the scapula down and back. So we're going to try that, okay? So what my daughter is going to do, she's going to, first of all, bend her neck away a little bit forward, and then she's going to take her shoulder and bring it down all the way in the back. She's going to really pull hard on it, okay? And then let go, and then hold very strong. So that will do the same thing. Doesn't work like that all the time. Sometimes it's just the manual manipulation of the nerve that will do it, or it's the stretch through the patient that will do it, okay? So of course you have to know how to get to the nerve. With your hands, when you know where the nerve is, you can just stretch it. You can just pull on it. If you don't know where it is, of course, you have to look in the anatomy book. And then if you want to go through it by the patient, of course, you can have to know how to get to the nerve through the patient, okay? So we have a whole course on that, on neuromechanics. That's part of our curriculum. It's more the advanced curriculum because we also have some training issues in there. You can also train your tissue like you can train proprioception of the joints. You can train proprioception of your nervous tissue. Yes, you can. Okay? So now we need to find a solution. So here we have a nerve that's coming out of the spinal segments, the cervical segments, cervical. I don't know right now. I don't have it in my head all. Usually I have all the charts on my wall, which I don't have right here. So it's probably around C3 to C6 or maybe C7. Somebody out there might know that right off the hand in their head. My memory has never been that good. I was more into focusing on what's here right now, and if I have to look up something, I have my wall charts. Okay, so here's my excuse for not knowing which segments are relevant for the nervus dorsalis scapulae. Okay, so what you can do now, you can activate the neck. Okay, so you can go through it step by step, saying, where does the nerve run along? So it's a motor nerve, so it's probably going to go to the motor cortex. At some point, it's probably connected to the cerebellum because the cerebellum is there to coordinate muscle function, all those things. But what we have to think about, and that's the crucial part, we should not think about too much about the function that nerve should have in terms of which muscle it innervates and what it's going to do, because we don't really know. And if anybody out there has the answer to that, which I haven't found, is where are the nerves going that are on the nerve, that are there to protect the nerve, that are measuring the mechanical forces on the nerve? Are they also going to the same spot the nerve itself is going, or do they have a different representation in the brain? A representation for nerve mechanics. So where is that? I haven't found anything yet. If you guys have found something, I'm happy if you would share that with me. Okay, so spinal cord, well, it's true, it's going to go through the spinal cord somehow. This is probably not a nerve that's going to go by the spinal cord, although if it's sympathetic, maybe we're not working with the proprioceptive part of the nerve, we're working with the sympathetic part of the nerve. Could be that there's sympathetic fibers coming out of the cervical ganglia. That could be. I don't know if that is true, but that could very well be, because usually those fibers then go along with the nerve and to the vessels in the nerve, etc. So we're just going to activate the neck. So what we're just going to ask her to do is just kind of circle her neck in any direction. We're just activating the neck. Okay, so getting some activation into those segments. Okay, and stop, and then we're going to pull on the nerve again. So I'm going to take the nerve, pull it down again, okay, and hold very strong. So that didn't change anything, okay? So let's assume the nerve is going through the spinal cord, and then the next step could be, if we're talking proprioceptions, we always think medulla, because that's where all the proprioceptive fibers are going, not all of them, but most of them, the spinobulbar tract, so the dorsal tracts that are going up, the dorsal parts of the medulla that are going up, that are not, they don't synapse in the spinal cord, they synapse in the brainstem and the medulla. So how do we activate the medulla? What kind of cranial nerves do we have there? For example, can I activate the medulla maybe through humming by activating cranial nerve 10? So let's try that. My daughter's going to hum. Okay, by humming, she's going to activate her cranial nerve 10. Hum, summen. Okay, so my daughter is going to hum. I don't know if you hear her humming. I'm going to put her on a microphone. There she's humming. Okay, she's going to hum, and I'm going to go on the nerve and find if I can do something here. Hold very strong. Okay, so there we have already something that works. So brainstem very often works because all signals kind of have to go through the brainstem. All signals, yes, I can't think of one signal that's not going through the brainstem. So we are, and I have to say hello on Instagram again. Thanks for watching here. So we have a solution to the problem in the nervus dorsalis scapulae by activating the medulla through humming. Okay, so that's going to be our integration. That's what we're going to do. We're going to integrate those two things, integrate the nerve with the humming. So she's humming while I'm stretching the nerve. And what I kind of like to do, this is not because that's the only way it works, but that's what I like to do, is to turn systems on and off. Okay, the on switch, off switch. So humming would be something like that. Turn it on and off. I like to do that. That's just a habit I developed, and I think it works quite well, but that doesn't mean that it doesn't work another way also, okay? So she's gonna hum, and we need to get the integration. So don't forget, the integration is here up there in the parietal bone, so that for some reason, since 30 years, we've been using that, not me, but my teacher has been using that because it works very well to facilitate nervous function integration. So what we do is we get down to the nerve, we hum, and we integrate. Okay, so that's the neurofunctional integration part. All right, so I'm going on the nerve. I'm just going to give the nerve some stretch down here. She's humming, I'm integrating. I can also do that at the same time, which doesn't work because she's slipping forward. I need to get down on that nerve, and I integrate that a few times to get the system to relax. Okay, what I could also do is I could also have her, like I showed before, stretch, go down on the nerve by pulling back her scapula down, all the way down, putting her head away, putting her head forward, and hum in this position, and just slightly move her scapula. So she could also do that. Let's try that. Okay, so it's already integrated, but I'm just going to show that. So she's bending her neck away, forward, and she's pulling down her scapula backwards and a little up and down. Okay, so work on the nerve while you hum. Okay, integrate that. All right. So here we have, that's what I'm claiming right now, integration through the medulla, because we're activating the medulla through the humming. Of course, it could be some other circuits also, because to hum, of course, we need to activate the cortex, etc. Thank you. That was very good humming today. Yeah. Okay, so let's test again. Okay, first what we're going to test is to go down and stretch the nerve, okay, mechanically. See, now it's not irritated anymore. Okay, now we're going to go back I'm back at C2. So now I have C2, and I don't need to stretch the nerve now. All I have to do is kind of run over the nerve. Yeah, I'm not stretching it, just running over. Okay, so here my reference is now saying nervous tissue dysfunction is fine. This is not a guarantee that this is going to cover all nervous tissue function. I'm pretty sure that, but it's quite good. So every time I find that it's probably a nerve dysfunction, usually, very often, and I don't have any statistics, 80% of the time, 90% of the time, 95, 85, I don't know. This correlates when I test that part of the body, which I suspect a nerve tissue dysfunction, with this part of the neck, which is C2, which is probably the myodural bridge, which is maybe the reason why this is so sensitive to mechanical issues in the nervous cable system. So it's a long cable system, all connected, all interconnected. If I pull on one cable, all the other cables are moving. So, and this is maybe the central points surveilling the surveillance of what's going on in the mechanics of the nerves. Okay, so that's important, like I said, because mechanical stretch will cause damage. So that has to be a system looking after the nervous system, the nervous tissue, to take care of it and keep us from overdoing it. So I have a lot of patients who have problems in their function, not only pain, but also in their mobility, not because they have a muscle problem, but because the nerve is signaling a problem, or the blood vessel is signaling a problem. And that's more crucial, because if there's a damage, especially to the blood vessel, I could die very quickly. So the body is very protective to those systems. So there's a lot of protection mechanics or mechanisms going on to protect blood vessels, but also nerves. If I lose the function of a nerve, I might not be able to move my leg anymore. So the brain wants to protect that structure very much, maybe more than a muscle, because if a muscle is damaged, it can heal better than a nerve. So I might be able to walk again. If my nerve is ruptured or damaged, maybe I'll never walk again. I won't be able to run from the lion. So that's why every time a patient comes in with an issue in the body somewhere, joint, knee, hip, back, I always take into account what are the nerves doing in a mechanical term. Are they free to move? Do they have any stress on them? Or is the proprioceptive system, I'm just claiming that it's there, the proprioceptive system of the nerve, is that overactivated through a trauma, through an accident or something, and it's still signaling problems in the nerve tissue, although there is no problem, okay? So this is why it's so important to look at the nerves. Very often the nerves play not a minor but a more major role in the problems, in the movement problems, in the movement issues, in the pain issues, etc. So it's worth looking at them. So here we are. That was my NeuroThursday for today. I'm saying thanks for everybody who watched on Instagram, and I'm saying bye-bye. Maybe I'll see you again in 2 weeks. And of course, you can always watch this video on Instagram TV. It's available there, and I'll get back to the Zoom people in 1 minute. Bye. See you.